So I'm going to speak for a few minutes about what the power the president has to shape or to reshape the direction of health care reform. So the Affordable Care Act is sometimes better known as Obamacare, originally a very derisive, derogatory term, and now in some quarters a laudatory term. But either way, reflecting the fact that President Obama was quite instrumental in getting this statute enacted and in also the early efforts to implement it. President Trump, of course, ran on repealing the Affordable Care Act and replacing it with something better. And he really has made extensive use of all the tools in his toolbox to try to do that. The very first executive order he signed, a few minutes after he was sworn in, directed his agencies to do what they could within the law to redo the rules, the regulations supporting it, and also to do what they could to ease up on enforcement of the statute. And we see activity in both those areas. One area of the president's power that's not much focused on in the literature, but is really important and very important in this area, is sub-regulatory action. And that includes managerial choices. So this is a piece of fake news. This is from The Onion, about the one place in America you can go to sign up for health insurance on the marketplace, that's in a cornfield in Iowa. But it reflects the real news, that this year Health and Human Services cut back extensively on advertising, outreach, and time availability on the marketplaces. And that's part of what has made them quite unstable and caused some insurers to leave and prices to spike. In addition, of course, to the president's repeated words that Obamacare is failing and it's gone and it's dead. So we've seen a lot of results from that. Of course, to actually repeal a statute, a federal statute, requires Congress. And Congress, particularly the Senate, has had great difficulty enacting a repeal, even a partial repeal provision. And that's partly because the ACA is already a very conservative, very free market approach. And it's really difficult, and maybe even impossible, to get more so while still keeping the pre-existing protections and broad coverage. So we'll see what happens at that arena. Of course, the courts are a big check on the power of the president. And we're seeing lots of activities in the courts now and have been for many years around the Affordable Care Act. One of the most significant decisions was the 2012 Supreme Court decision. And one of its impacts was to give the states a lot of power to shape their direction of health reform. This is a map of the current status this year of Medicaid expansion. So the Supreme Court allowed states to choose whether or not to expand their programs. The blue states did, and the orange states have not yet, except Maine actually voted a couple weeks ago to expand next year. We'll see what happens with that. Another area of state activity, and Jeff Sconyers will talk about this, is the ACA provides support for states to do various innovative programs. He'll talk about some going on in Washington State in that arena. We've also seen a lot of uprising of public pressure on Congress, lots of letter writing, demonstrations, town hall type events around the Affordable Care Act and health care provision generally, and really seen sort of a shift in public opinion around the role of the government. And Aaron Katz will be talking about what that might mean for options going forward. A real significant shift in public polling and some public pressure activities. So I'm just going to briefly do a case study, talk about a case study and how the president really does have the power to sow significant chaos and to put sand in the gears of the Affordable Care Act. And yet it marches on. This has to do with what are known as cost-sharing reduction payments. So under the statute, insurance companies have to reduce the out-of-pocket costs for certain low-income and moderate-income purchasers. So instead of having a $7,000 deductible, somebody might have a $500 deductible. So the law requires insurance companies to reduce these out-of-pocket costs up front and then get paid back by the federal government to the tune of about $8 billion a year. Because of some ongoing litigation over this badly worded provision, the president gained the effective power to decide whether or not to keep making these payments. And throughout last spring and this summer, he went back and forth. Yes, he would, no, he wouldn't, wait and see, maybe, maybe not. And then in October, he announced that he was stopping them effective immediately, about 2 weeks before the marketplaces opened. And this is a chart showing the Kaiser Foundation's prediction about by how much premiums would have to rise to offset these lost dollars, these billions. So between 15 and 21%, depending on the marketplace. And that's about what we saw. At the end of October, states revised their rate approvals and allowed the premiums to rise by, I think, average of 17, 18% throughout the country. And so for consequences of that, one, those who get a premium subsidy are actually shielded from this, because when the premium goes up, the subsidy goes up to keep the amount an individual would pay at a set level. So they're pretty well shielded. In fact, the way that it wonkily works, they might actually find some better deals this year than last year. Secondly, those that do not get a subsidy, so somebody who makes more than $50,000 a year does not get a subsidy, they're facing the full brunt of this. You know, in some places, premiums are up more than 50% from last year. And that's a lot of people, actually. In our state, 40% of the individual market purchasers do not get a subsidy. We have a relatively high-income state, a lot of entrepreneurs. Another consequence is that the markets are very confusing. It's very difficult to shop on them right now. And fourth, I don't think the president anticipated this. The federal government will probably actually spend much more, because it'll save money by not paying these CSR payments, about $8 billion, but that will be more than offset by the increased premium subsidies. So what's going to happen? There's ongoing legislation. Patty Murray has proposed litigation. How will the public respond? We don't really know now. What is certain now is that everybody, or at least most people, know how complicated healthcare reform is. And despite President Obama's determination, he's not going to be the last president to deal with this issue. So. Turning it over to Jeff.
So, meanwhile, back in the other Washington, back here, we have our own set of issues. DC may be in chaos, but we've got problems we have to deal with right now. Homelessness is, as was just published, Seattle's public health epidemic crisis here in the city. Access to care is challenging here in our state. We've got a set of providers. So Walla Walla General Hospital, one of two hospitals in Walla Walla, went out of business this summer because it couldn't make any money anymore. So we've got one set of problems where people just can't get access to care because providers aren't there for them. But on the other hand, we've got problems of access to care because people who are supposed to be providing care for the most needy and underserved portions of our population aren't doing so. So our state attorney general has sued one hospital in Tacoma, that is St. Joseph Medical Center, and another in Olympia, Capital Medical Center, saying they don't provide enough charity care for our citizens. Mental health services are inadequate. I know you can't read this chart, but what it shows is that we have the third highest incidence of mental health diagnoses in the country, and the third lowest availability of inpatient psychiatric beds in the country. So these two things are not a good match. We don't have good access to mental health services in the state of Washington. And while the opioid crisis is a bigger problem in other states than it is here, it's not great here either. We have our own opioid crisis. There's been an 18% increase in deaths attributable to any opiate between 2002 to the current year. So it's a big change and a big issue, and it's affecting lots and lots of people. So what are we doing? Well, Washington has adopted something called Healthier Washington. This is one of the waivers from the standard rules for Medicaid programs that we got from the Center for Medicare and Medicaid Services. And what it is a strategy to promote healthy communities, integrated care, and to move to payment for value. And this is intended to achieve what we all refer to as the triple aim, right? Better care for individuals, better population health, and lower cost services. So we've got a series of strategies that are meant to do that. They're all being enacted through this demonstration grant. The contract with CMS sets very clear guidelines, very clear goals that we have to achieve. And it provides for a huge honking amount of resources, of up to $1.5 billion that we can spend on improving the healthcare delivery system and improving the healthcare of citizens of the state of Washington. But it's not a grant. We only get this money if we actually achieve results. And the goals for 2019, okay, so it's almost the end of 2017. So what are the goals for 2019? 90% of residents of the state of Washington will be healthier using objective measurements. We will have integrated to a large degree physical and behavioral health services. So right now, those two worlds operate just almost separate from each other. You get your checkup, and whether you have a mental health issue or not, those two systems don't talk to each other. We'll have annual cost growth in the state of Washington that's 2% lower than the national trend. Now, that doesn't sound like much, but that's a big difference. And 80% of our market will have shifted to an integrated value-based payment system. So right now, if you go to a healthcare provider and you have a procedure done or you have a visit, they get paid because they did something, whether you got better or not. So we're going to move 80% of our market to value-based. We're actually going to achieve results for patients. What a concept. And we are also, by 2019, going to achieve savings of $700 million. That's a lot of money. I don't care what anybody says. We're going to achieve this through something called accountable communities of health. So there are 9 accountable communities of health around the state. And today is, what's today? I think today is, yes, it's the due date for proposals for each of the ACHs to submit their plans to the healthcare authority in in Olympia, for what projects they're going to work on between now and 2019. So there are 8 total projects that they can choose from. In order to get funding under that up to $1.5 billion that's available, they have to do at least 4 of these projects. And they are required to do 2 of them. One is they have to do something on the opioid use crisis, and they have to do something on the bidirectional integration of behavioral and physical health. Other than that, they can choose up to 8, but they have to choose a minimum of 4. And they get funded depending on how many of those projects they do. But understand, they don't get any money up front. They only get money when they achieve the goals that they've set. This is a really different approach to making change, because usually what we've seen is people get money, and then whether they achieve change or not, they already have the money. So this is a big challenge. If you look at some of these ACHs, you can see King County, right? 1 county, Pierce County, 1 county. Look at the greater Columbia region. What does Ellensburg have in common with Walla Walla, except they're out in East Guam? What do some of these regions, how well will they function? It's a big challenge. So what could go wrong? Well, okay, you're laughing. So first of all, year 1 funding for the ACH projects has already been cut by about 36% from what the ACHs expected. So when they went through and they calculated about these various contracts with CMS, they wound up with about 36% less than they thought they were going to have. As Sallie's mentioned, we've got some ongoing hijinks in Washington, D.C. that could affect the availability of federal funding. There's a real question in everybody's mind about whether it's possible to shift 80% of our purchasing to value-based purchasing over a short period of time. Is it possible to make 90% of the people of the state of Washington healthier over a 2-year period of time? Even if we can figure out how to measure that, is it possible to do it? We've got workforce shortages, and let me just say, there's a lot of inertia in the system. Can we integrate physical and behavioral health? At each one of these ACHs, there's some kind of governing board, and at the governing board, there are representatives of the traditional healthcare provider environment, deciding who's going to get what money for what projects. To me, this sounds a bit like the fox guarding the hen house. And are we even going to try to attack the root causes of health outcomes? So when we look at homelessness or mental health issues or education. These are the things that really drive, these are the social determinants of health. It's not so much healthcare services, but what we're attacking is healthcare services. And to throw an additional wrench in the work, just this week, the Washington State Supreme Court said that the McCleary solution that the legislature came up with to fund our public schools is inadequate. So there isn't a lot of state money sitting around to actually fund any of these changes. Other than that, it's going to be pretty easy. So Aaron is going to explain how we're going to make lemonade out of these lemons. Thanks.
I was gonna hold this off until the end, but I'm gonna say, I mean, a number of things that Jeff talked about. Any of you who have the notion that the educational process that happens here at the University of Washington is sort of theoretical and unconnected to reality. So he talked about value-based purchasing. I have a group of students right now, and in fact, my 3 students, you're working on that project. So we have a group working on value-based purchasing as a project for the State Healthcare Authority. In 2 weeks, another group of students in another class that I'm teaching, they don't know this yet, are going to be working, they're going to be analyzing those plans from the accountable communities of health to look at the extent to which those plans actually address equity issues and social determinants of health. So it's like real-time work that our students are doing. So I just want to put that out there. That, I mean, it's amazing work. I'm still amazed. I mean, we give them these assignments, and how they do them, I'm not really sure. So we solved the problem of healthcare reform, but just take a little bit of a step back, and then we're going to go forward. So I love this cartoon. This is the healthcare system in the United States before the Affordable Care Act. It was a mess, right? Yeah, I mean, it was impossible to navigate. So what did the Affordable Care Act do? Well, it didn't, we used to use whiteout. It didn't use whiteout on this at all. So it overlaid a number of additional appendages on this existing system. So we have these insurance exchanges for people who who have to buy insurance themselves in the individual market to make it a little bit easier for them to do so. We created these real cool things called health insurance co-ops, most of which have failed, by the way. But the idea was that co-ops are nice and fuzzy sounding things. We had Group Health Co-op and we have Puget Consumers Co-op, that somehow inserting a co-op into an otherwise dysfunctional healthcare marketplace would solve the problem. Sallie mentioned Medicaid expansion, which has actually done a lot of good, and a bunch of mandates. In the paper now is the fact that the Senate Republicans are going to propose repealing the individual mandate in their tax proposal. But the point is that, the healthcare system that we knew before the Affordable Care Act pretty much is the one that we have now with some Band-Aids. Okay, now, if we're looking ahead, so if we had a functional political system, we'd have a Congress that was attempting to solve real problems, and there are real problems with the Affordable Care Act. Lots of people, and we still have a fair number of people who don't have insurance, and we have lots of people who have insurance with really high deductibles. So they can't afford the care even though they have an insurance card. There are problems to be solved. So there are, in fact, some politicians that are attempting to solve some of those problems. So our own U.S. Senator Patty Murray and Lamar Alexander have developed a bill to try to stabilize what Sallie appropriately described as an unstable individual market. So they've proposed to extend the subsidies for those cost-sharing issue that Sallie mentioned, extend those for a couple of years. Open up catastrophic plans, meaning plans that don't cover much, but for people who want to buy plans that don't cover much for cheap, open up plans for more people, and give states a lot more flexibility. Also being discussed is what was dreaded during the run-up to the Affordable Care Act, the public option. You all remember that? This horrible sort of socialistic notion that government should offer an insurance plan to compete with the private market. And somehow that would encourage the market to behave appropriately. It was not included in the Affordable Care Act, but it's now back on the table. And there are a number of proposals to either allow people to buy into Medicare or to Medicaid. And why that's important is, I don't remember, Sally, if you mentioned that there are a fair number of counties around the country in which there is either one insurance provider or none in the individual market. So people have no choices or one choice. So being able to buy into Medicare and Medicaid means that anybody anywhere around the country would be able to buy into an insurance plan on the individual market. So that's that's trying to solve a real problem. That's worth some debate. Then there's the even dreadier single payer idea. So this idea was never really allowed into the debate running up to the Affordable Care Act. In fact, people were thrown out of Senate hearings for even suggesting this idea. But it's back on the table. And it's largely back on the table because of this guy, Bernie Sanders. And if you like this idea, it's because he looks like kind of one of us academics, He's not wearing a tie, he wears this coat, he looks really trustworthy. And the notion of a single payer, Medicare for all in particular, is that over time, his bill actually would, over a 4-year period, incrementally open up Medicare, which is now just for people my age, 65 or older, to younger and younger people until it covers everybody. So you have a single program already exists that would cover everybody. So that seems simple, and so people like it, kind of look at this picture, yeah, I want to do that. Of course, people who don't like it look at this picture and see this doctrinaire, table-pounding guy. It's an awful thing because he doesn't compromise about anything. And then, of course, lots of people are just confused, and it's probably because of this picture. Like he put his fingers into a socket or something like that. Anyways, this is actually on the table. There is actually a bill in Congress. It will be debated. I'm not going to bet my retirement that it's going to pass, but it's a real alternative to the mess we have. Okay. So what's your role in this issue going forward? What's our role? So just to say from the School of Public Health, I've been here for 30 years, and I've done a lot of work with policymakers at the local, state, and national level. And the University of Washington School of Public Health is a well-known, reputable source of the best information about what's going on in the health sector. Okay, we produce really good information, and our students, as I said, produce really, really good information. But that's not enough. That's not enough. A well-functioning democracy requires informed and active citizens. So Sallie mentioned that public opinion about the Affordable Care Act has changed, and she mentioned, for example, the vote in Maine. So the governor of Maine has refused to expand Medicaid. The voters a few weeks ago voted to expand Medicaid. The voters said, we want this for our citizenry. Okay, so that's an example of people raising their voices. Other examples, well, we had an election last November. We elected a Republican president. We had and still have a Republican majority in Congress. Well, and they've been talking about repealing the Affordable Care Act since it became law. And of course, it would happen, right? Because they own Washington, D.C. But it didn't happen. And one of the reasons that it didn't happen is that people got together and raised their voice and said, no, repealing the Affordable Care Act is not acceptable. We need to fix some stuff, but repealing it will hurt a lot of people. So our voices matter. If we organize, if we band together, we can make a difference. So our job collectively, whether we're academics or whatever we are in this room, is to raise our voices and let our elected officials know what we want from them. Thank you.